Hi, morning.
Morning.
Hi, Dr. Walkden. Thanks for joining us. We're going to start shortly. You're welcome to start sharing your screen if you're happy.
Yeah, no problem at all. Doo-doo-doo. Can you see that, I hope?
Perfect. We can see that.
Am I destined never to see you guys? Is that the way this works?
We will put our video on. Right.
There we
Dr. Walkden, Prof. Lazarus would just like to say a few words of introduction before you start.
No problem at all.
Testing 1, 2. 1, 2, 1, 2. Ik heb het 1, 2, 1.
Hello, Miles. It's John Lazarus here. How are you?
Not bad, eh, John? I'm very, very good. I can't complain. I'm enjoying the Plet sunshine. So yeah, all's good.
Good. So just to introduce you to the colleagues here, we've got some fifth year medical students here from the University of Cape Town and some registrars and some supernumeraries. So Miles, we're very grateful that you've taken time out, particularly so early in the morning. I hope you've got your coffee there with you. But it's really a
Plenty of coffee already, don't worry.
privilege for us to have some input from interventional radiology. We've got really improved service over the last few years with now two interventional colleagues. I did invite them, and then they will be joining us online. Let me check if they are there. Jatil is one of our colleagues, and so just to say that I think I'm correct in saying that the Institute of Urology is at UCL, and
That's correct.
I've also personally worked at the Royal Free, and I can assure colleagues that Miles works in the best part of London, beautiful leafy part of North London. So wonderful to have you joining us today, and I think this is going to be important for the trainees to get a bigger picture of the academic side of interventional radiology. So thank you very much.
No problem at all. Can I just check, John? How do you want me to keep going for an hour, or what's the
Yes, we
story?
got 7 to 8 is our usual slot.
Fine. Okay, perfect. Good. Okay. Right. Okay. Thank you very much for that introduction. I'm Miles Walkden. I work at both the Royal Free and the University College Hospital London, and I'm an interventional radiologist. I concentrate mainly on renal ablation these days. So I'm just going to hopefully walk you through that. I understand that you are obviously all urologists, and please forgive me if I'm saying things that you obviously clearly know. Um, so. I think renal cryotherapy is probably the best ablation method for treating small renal masses, but we'll get to that. I am a proctor for Boston Scientific, which is one of the companies that makes one of the cryo machines. So quickly, this is for Jatil, everyone, the IR's on the thing. So most people, we go into radiology, we have an easy life, especially with technology these days, you can sit at home and work on your computer, but as IRs, we want to be a bit more involved. We like doing things. I asked one of my colleagues why he became an IR doctor he transferred over from surgery, and his answer was because he didn't like patients. I think the problem is to take it to the next level as far as IR and intervention goes. You've got to get involved in clinics. And here, for example, is a clinic I did not so long ago. and you've also got to get involved in the MDT. So I'm sure there is a renal cancer MDT. If you get involved in that, then your referrals are going to come right up. So what are the problems? The problem, first of all, is the small renal mass. So we're all faced with it. Again, an example there. So what the first question is, what is it? Obviously, it can be both benign and malignant. And if you just purely go on the stats, if it's less than 4 centimeters, benign 20%, malignant 80%. But that's pretty much it. Unless it's got fat in it, on imaging, you can't really tell. But we can use something called the clear cell likelihood score. I don't know if you guys use it. That's sort of useful. And then also biopsy at the Royal Free. We're doing a lot of biopsy now, but that's obviously quite invasive. It's got complications associated with it. So first problem is, what is it? And there's some more examples. Can we differentiate between all these different small renal masses? That's a clear cell likelihood score. The problem is it's based on MRI, and most patients before getting treated tend to have CT. There is a CT version that's out there. It's just not as accurate. So when we come to talking about, just get rid of that. When we come to talking about renal cancer, in the UK, it's about the 6th to 7th most common cancer. It's a cancer of the elderly, so that is important. And it is increasing exponentially in numbers, expected to be the fastest increase in cancer over the next 20 years in the UK. I don't know what it's like in South Africa. The other thing to say is that the 5-year survival rate, if you've got a stage 1, so a T1A tumor, is excellent. So it is not at that stage a particularly dangerous tumor to have. So that brings us to the next problem. So you've got a small renal mass. Is it actually beneficial to treat? I don't know if you guys use the Charleston comorbidity score, but if you look here, these are the probability of a renal tumor killing you, and it's based on size and also the Charleston comorbidity scores. So here, a Charleston score of 3 or more, which, remember, a Charleston score, you will get 3 points for being 70 years or plus. So it doesn't take much more. If you're 70 years old and you've got hypertension, you've got a Charleston score of 4 already, and the probability of a T1A lesion causing mortality compared to all other causes is tiny. So you really do have to think about whether treatment is beneficial to the patient or not. Then the next problem is you've got numerous options. So you've got active surveillance, you've got surgery, you can do a radical, you can do a partial, you can do an ablation, you can do microwave, IRE, radiofrequency, and now they've added another one in, you can do SABR. So you've got all these treatments that you can offer. Now, obviously, surgery has been the traditional option for the small renal mass, and traditionally, it wasn't that long ago, you got an enhancing mass in your kidney, well, we're just going to take out your whole kidney. Obviously, that resulted in a lot of radical nephrectomies for benign disease. Then we introduced partial nephrectomy, and the whole reason for introducing partial nephrectomy was to try and prevent a decline in renal function for similar oncological outcomes, and it was especially important in hypertensive and diabetic patients. However, it is significantly more challenging. And this is the lovely thing about ablation. It's fairly simple. For you guys, you're technically far superior to anything that I can do, but that means there is a learning curve with it. And it does tend to mean, at least initially, there's an increased complication rate. So your radical, this is a Roboc-assisted partial, which I think you guys are transitioning to now. Laparoscopic partial nephrectomy is an excellent operation. The advantage of the robot, I think is there, but there's a lot of cases where it's not. Many steps. You have to give a pneumoperitoneum. You have to do a complex dissection, resection, hemostasis. You've got that warm ischemic time, so you're working against the clock, and you've got a learning curve. And it is quite invasive, so your patient will take a little while to get over it. 4 to 6 weeks. They're in hospital maybe at least 1 to 2 days. I don't know if you guys know this chap, but he's now a prof, Ben Chalicum. I was at medical school with him. He likes getting in the newspapers. Here, he was talking about his playlist. He's got a terrible playlist if you look at some of those songs on there. But the last song that he doesn't want to hear is Oasis, and his playlist is 30 minutes. That is working against the clock. You've got to get things done because of your warm ischemic time. As far as evidence goes for partial nephrectomy, because we are going to get hammered for the evidence for ablation, but actually there's only ever been one trial comparing partial nephrectomy with radical nephrectomy. There are a lot of problems with this, but I stress it is the only evidence out there, and actually it says that radical nephrectomy has a better overall survival. There's a lot of problems with that paper though. So what about ablation? Ablation, as I've said, it can be microwave, it can be IRE, it can be cryotherapy, it can be radiofrequency. But all you're doing essentially is placing a needle into a tumor, and you're applying some form of energy, and therefore it has to be less invasive, number one. Okay, so that means it's going to have less of an effect on your renal function. It is certainly cheaper. Every hospital I have ever been in owns a CT scanner already. You don't have to buy a robot. Certainly, if you're talking about cryotherapy, you can potentially, if you want. I don't do it, but you could do it under local anesthetic or local anesthetic and sedation. I can certainly listen to Oasis, unlike Ben Chalicum. So the question really is the oncological outcome as good? And absolutely, I'm not saying that ablation can treat every lesion. There's some lesions we can't. And then you've got to choose which modality out of all those ablation ones that you want to use. So top right here, this is what the ice ball looks like. So you can see it. Bottom here, you can see this guy's had an open partial before. This is a patient with VHL. They've also had 2 ablations. I don't think you'll be able to tell or can see where that's happened. So what is the advantage of cryotherapy over other thermal ablations? I think you've got microwave. I'm not sure whether you've got cryo, but I've seen something in the press about you having microwave. So for me, cryotherapy is better than microwave. Number one, the most important thing is we're radiologists. We like to see things. You can see the treatment ice ball. Okay, so that's really important. Because it's a multi-needle modality, you can also sculpt the ice ball. So you can increase at one needle, decrease another one to protect structures. You can treat deep into the collecting system. Microwave, you can't do that. If you put a microwave probe in anywhere near the collecting system, you will end up getting a leak. It means you can get closer to critical structures because you can see it. That allows us to treat larger tumors. Okay, and it does, because it's a freezing, not a heating method, it is considerably less painful. And then there's also a little bit of work to see does it generate an immune response. So this is an example of someone doing a microwave. So you can see there's the tumor on the left. They put their probe in. There's a load of bowel at the front, and then you can see that's the end result on the right. Now, the only thing I would say about this is, do they know if they've treated the bowel, yes or no? Whereas if you take the cryo equivalent, there's the lesion, there's the ice ball. I know that I've treated my lesion. I know I've gone a little bit into the liver, but I don't care about that. And that's what it looks like during treatment. So this is just an example. You can see, I promise you I am a nice guy, but this is me doing a cryotherapy. There seems to be no other person around, but there is a patient in there. The anaesthetist, as usual, is reading the paper. I presume they do that in South Africa as well. In the CT scanner. So this is the cryo machine. Here is the argon gas, which is the gas that causes the freezing. This is an old photo. So we used to have helium to thaw things, but we've got rid of that now. So again, here is the lesion. There are the probes going in. These are, again, the old probes, so they're not insulated. So I've had to put gel around them to stop the ice ball going into the skin. And then here we are freezing. That's what it looks like. And then we're done. So how does cryotherapy work? So we put the needles in. They're hollow on the inside. And what we're doing is we're pumping argon gas into that needle. And there's an expansion chamber. And as it expands, it drops the temperature down. So the temperature on a cryo needle gets down to about minus 140. And then what that does, it kills in many ways. It's got direct mechanism of kill. So if you create ice directly in a cell, you're going to burst that cell open. It also has osmotic injury. So if the first thing to freeze towards the periphery of the ice ball is the extracellular water, If you freeze that, then the osmolality goes up, and then that draws water out of the cell. And so you have an osmotic injury as well. And then indirect mechanisms is you cause thrombosis of the blood vessels, and you can get apoptosis. So it's a bit like the Joule-Thomson effect. If you want to feel it for yourself, get an aerosol can and spray it. You'll notice that the can gets colder. So factors affecting cell death in cryotherapy, the ice ball temperature. So the lower the temperature, the better the kill. The freezing rate, the faster you freeze and get that temperature down, the better. Number of cycles. And this is in one of the disadvantages with cryotherapy compared to, say, microwave. The treatment cycle for cryotherapy is half an hour. So after you put all your needles in, you've got half an hour of treatment. Compare that with microwave. You put your needle in and you're treating for anywhere between 1 to 6 minutes. So there is no question that microwave is faster. Passive thaw is also vitally important. That's a 10-minute passive thaw in between, and how long they last, so 10 minutes again. So what is the guidance currently? Well, the kindest guidance to ablation is the AUA guidance, and that says basically for any T1A lesion less than 3 centimeters, you can offer it to all patients. The EAU guidance, however, sticks with ablation should be used in the elderly or the comorbid patient. This is the latest guidance, so this has just come out at the Royal Free. We work with Axel Becks, who's kind of like the godfather of a lot of renal stuff. And it hasn't really changed, but it does make it in, so that here you can see candidate for surgery, T1A lesion, surgery, and they've just written alternatives are cryo, RFA, and microwave. So what are the indications for ablation? So again, we still say at the Royal Free that the gold standard is nephron sparing surgery. However, we would consider ablation if the patient doesn't wish to undergo surgery, if they're too unfit, solitary kidney or poor renal function, a genetic predisposition, so something VHL, or if the tumor position would necessitate a radical nephrectomy, but ablation is technically feasible. So actually, in my experience, when I started off doing renal ablation, I became an expert in psychiatric disorders, specifically schizophrenia. But it's funny how surgeons don't want to treat the slightly mad patients. I got a lot of those. The morbidly obese, to start with, I thought that was terrible. Actually, morbidly obese patients are brilliant candidates for cryotherapy because there's so much fat around the kidney that it allows treatment easily. People on anticoagulation and previous abdominal surgery. So this is how it worked. I don't know if any of you know the chap on the left there. That's a guy called Chris Anderson. He's a South African urologist. I think he trained at Witwatersrand. He now works at St. George's Hospital. But this is kind of how it went. And I'm sure this is how, if you're starting off a service, you'll find that, you know, the young, fit patients go to the urologist and the morbidly obese go to the interventional radiologist. That's okay. That's absolutely fine. So where can cryotherapy help? Obviously, we've talked about the morbidly obese patient, endophytic lesions. Sometimes, I don't know if you guys have got ultrasound or use it, but obviously the advantage of doing anything under CT guidance is you can see it very easily. So it's very good. Solitary kidneys, again, we do a lot of solitary kidney work. You can treat quite big tumors in solitary kidneys. Because there's no warm ischemic time, the effect on the renal function is minimal. So solitary kidney is really good indication. Poor renal function, if you can see the lesion on a non-contrast CT, you can do ablation without giving them any contrast. So this was a guy, you know, had I think an EGFR of something like 15, and we treated his lesion, no contrast required. VHL, I really do believe that anyone with a hereditary disorder like VHL should be getting an ablation as their first up treatment, because we can just keep going back, and again, no warm ischemic time. Tumor position is important. Yeah, I've got a colleague, David Breen. I don't know if you've heard of him, but he's kind of like the guy that started off in the UK. He says that we can treat absolutely anything. I agree with that to an extent, but location does play a part in our decision making about how easy something is to treat. So the red does not mean that we can't treat it, just means you have to think. So when you're sitting in MDT and someone says, can you treat this lesion? If it's on the outside there, upper, inter or lower pole, those fairly easy. Okay. Then when we come medial, the problem with coming medial is the renal pelvis. So you just have to think about the renal pelvis. We can treat there, it's fine, but you may need to put a stent in. You may need to do some ancillary maneuvers. The thing everyone forgets about is the ureter. Okay, so the lower pole, you've always got to worry about the ureter. Anterior lesions, there's always a criticism that ablation can't treat anterior lesions. We can, but really it depends on the patient's body habitus. And then the sort of more tricky thing is the anterior and medial, again, for the same reasons, renal pelvis and the ureter. So what are the problems with ablation? The problem with ablation is there's been a real scattergun approach from IR. As IRs, we are not good at putting evidence together. We're not good at setting up trials and that kind of thing. Plus the fact we've had all of these different modalities that people have just sort of played with. So we've had RFA, microwave, IRE. There are massive variabilities in practice. So some people will do it under ultrasound guidance, some people do it under CT guidance, some people will do it under local anesthetic, general anesthetic, sedation. We only have small series numbers. There is no randomized and comparative trials. So we have got ourselves into a bit of a mess as far as ablation goes. The level of evidence is currently poor. So there's loads of single center reports, retrospective reports. However, randomized controlled trials currently, although we'll come to this, there are none. So we must do better. And that's just confirming the fact that we have very limited data. But what is out there is very positive, even though it is retrospective. So this is one of the bigger ones from Houston Thompson. And here you can see they were comparing partial with RFA and cryoablation. And actually the local recurrence-free survival was very similar. And the metastasis-free survival was slightly better with partial nephrectomy. So if you look at the metastasis-free survival curve here, cryo and partial nephrectomy, they're virtually together. But the retrospective unmatched data, these were SURAB and CONSERVE were two trials that were supposed to be able to answer this question, but they failed to recruit. And the reason they failed to recruit was because at this stage, there were no IRs in any clinic. So the person consenting the patient potentially for their ablation was a urologist. Now, that's a bit of an unusual situation where you've got the person that doesn't do the procedure, consenting the patient for it. This is data from the UK. So this in the next slide, this is David Breen's data. This is 220 patients, all biopsy proven, so that's important. And you can see the local recurrence-free survival was 97% at 3 years, 93% at 5 years. Metastasis-free survival also high, and the major complication rate was around 4.9%. Okay, this is my data. This is a while ago now. I need to do this again, but this was our first 180 patients. And you can see major complication rate was low, 2.1%. Local recurrence-free survival was good. We've had, at that point, we had no METs and no deaths. I have had now 2 patients who've had metastasis, but we're up at about 850 patients we've treated now. And you can see the renal function doesn't really change. So in order to try and answer this question of can we do a randomized controlled trial at the Royal Free, I worked with someone called Professor Maxine Tran, and she set up this trial, the nephron sparing treatment for small renal masses trial, NEST trial. And what we did was we randomized 25 patients to partial nephrectomy, 25 patients to cryotherapy. And this was just a feasibility study to see, is it feasible? Will people consent to allowing us to randomly assign them to cryotherapy or not? And thankfully, we were able to do that. The surgical group, unfortunately, had 2 conversions from partial to radical. And the mean hospital stay we in cryotherapy 1 for the partial group was 2 days, Interestingly, there wasn't a significant change in renal function in either group. But this basically has now set the groundwork for this. So this hopefully is coming in the summer. Again, this is Maxine Tran, and this is like it's exactly the same thing as NEST, but it's going to be a national trial and multi-center. So we are hoping to recruit over 1,000 patients, and we're looking to randomize 556 of those. So hopefully this is the thing that is going to answer the question about the oncological outcomes between partial and renal cryotherapy. I stress this is just for cryotherapy. It does not include the other modalities, does not include microwave and RFA. So look out for that. That's coming. We're quite excited by that. So now I just thought quickly I'd sort of try and give you an outline of how we choose lesions and stuff. So if I was to ask the IR online, which lesion would you prefer to treat? I think probably the answer would be the one on the right. They're the same. They're exactly the same size tumors, but we would prefer to treat the one on the right. Why? Because this is an obese patient, and you can see all this fat around the edge of the kidney compared to this skinny patient. So if we're creating an ice ball, we have to take a margin. We have to get a margin of at least 5 millimeters, ideally a centimeter, to make sure that we're getting good cell kill. Well, here, if you're taking a margin of a centimeter, you're going to be into the posterior abdominal wall. Here, it really doesn't matter. Nothing's touching it. So people often ask, how big a lesion can you treat with cryotherapy? That is not the question. The question is, what is the patient's body habitus like? So fat patients are great. We can do ancillary maneuvers to manipulate what the lesion looks like, and I'll come to that. Where it is, I've shown you the position thing. Ideally, we like the posterior lesions, but you can treat most lesions. So how do we work up our patients to the Royal Free? So I like them to have had imaging within the last 6 months. I will biopsy all of them beforehand, so I'm definitely treating a tumor unless they've got VHL. I will occasionally biopsy at the same time as doing the ablation, but that is patient choice. They don't want to have a biopsy. They don't like the idea of it, so we'll do it at the same time. But no one, apart from the VHL patients, will get the treatment without a histological confirmation. Bloods, I do an MSU on all patients, and I do treat mixed growth. One of the things you really don't want to have is an infected ablation zone. Anticoagulation, obviously stop it. I don't mind continuing aspirin, that's not a problem. And most of the time, providing there's no bleeding, you can get back onto anticoagulation almost immediately. And I do, if they have got renal calculi, ideally they should be treated before you go ahead with the ablation. So the patient position, the position that you treat the patient in is vitally important to how easy it is to treat the lesion. And so will either just before the treatment get the patient up on the table while they're awake and put them into all sorts of different positions. But the standard position would be prone with the arms up. But very happily, if the lesion calls for it, treat them supine, semilateral, whatever. And we have a whole load of gels, etc., that we can manipulate the position of the patient in the CT scanner. So just an example of how position does alter. This is the same lesion. So you can see if you've got them in the lateral position, you've got bowel anteriorly. If you've got them prone, you've got bowel here. And if you turn them purely prone, this is with a Montreal mattress, that's no good because the bone comes in the way. But that's just to show you that the position of a tumor changes drastically compared to what position you place the patient in. So, we can do supine treatments. It's good for anterior lesions. So there's a big tumor here. And so we just turn them slightly on their side. The only issue with this is the bowel is here. So we've got to make sure we get that out of the way, which we can do with hydrodissection. We get in and treat, and then that's what it looks like. Again, another example of how manipulating the position that the patient is in changes things. So if you have someone purely prone, you can see here there's lung in the way. If we turn them a little bit right side down, what happens is the lung gets squished out of the way. You don't need to worry about the lung. The next thing, which I guess is important for you guys out here, so one of the advantages of certainly cryo is that you could potentially do it under a local anesthetic. I've done a few cases, not many, probably 5, purely under local anesthetic. I've done a case recently under a spinal, or most of our ones we do under general anesthetic. And again, not every general anesthetic is the same. You can do general anesthetic. Normally, you can general anesthetic with breath hold, and you can do general anesthetic with jet vent. Now, I'm very spoilt and we like using jet vent, but it really depends on the experience of the operator. I think if you're just starting out, it'd be much better to have the patient asleep rather than awake. Also depends on the patient. This patient, this patient here on the left with interstitial lung disease. This is the one I did purely under local anesthetic because no one wanted to do anything with them. If you've got an anxious patient, obviously trying to do something under local isn't going to work. Doing the biopsy is often quite a good test about how anxious and how well people are going to tolerate the procedure. So we use this thing called jet vent. I don't know if you guys use jet vent, but basically,
So
I'll just let my anaesthetist explain it.
trace, which is the final normal tidal ventilation, and you've now just got oscillatory flickers of end-tidal CO2, which mimics oscillatory movements on the jet ventilator. There's another check. You can just see that the tidal volumes, rather than being 500 as they were before, they're now in the low 200 to 100 to 200. This is actually 232.
So what that is just instead of the normal bellows where you take a big inspiratory and expiratory tidal volume, there is a little diaphragm in the ventilation machine, and it just oscillates. And so what that means is nothing moves. So part of the problem for treating renal lesions is the kidney can move up and down by sort of 4 to 5 centimeters inspiration to expiration. So it's a moving target. But if you look at this is someone with jet ventilation. I put the artery forceps on the laser light on the patient. So this is how I'm lucky enough to be able to do my ablations. So you can see nothing's moving. Nothing moves at all. Do you need to do that on everyone? Not at all. Does it help when you've got a complex case? Absolutely. So I think as far as the anesthetic question goes, it depends on the lesion very much. And we did, this is just a little paper from some time ago where we basically just proved, unsurprisingly, that the jet ventilation did reduce the procedure time and the needle placement time. And it also reduced the dose for the patient. So just, I think I've only got a few cases, but here's sort of a pretty classic thing that we would take on. 75-year-old male, 4 centimeter tumor, so only just a T1B tumor. Renal score of 9x, EGFR 73, Charleston score 3. So here it is. So that's where it is. So we're good to go on that. So I treated them in the prone position. So they are prone. I've put 4 force needles in. So we have different needle sizes. The workhorses are the sphere and the rod. And then you also have these big needles called the force. So put them in, total treatment time from start to finish. So from putting the patient to sleep to waking them up, 85 minutes, the dose 703. Here we are putting the needles in. You can see they're in there again. Beautifully, you can see the ice ball forming. And that's what it looks like afterwards. So this is the pre here. Axial and coronal, and this is the post. So you can see the treated tissue is larger than the tumor itself because we have to take a margin. So we know that we've covered it well. So what things can we do to try and make sure that we don't damage surrounding structures? So hydrodissection. So what we do is you get a litre bag of saline, you put 20 mils of contrast in it so you can see it, and then you put another fine spinal needle in, and then you can inject it. It's very good for moving things like bowel. So here you can see there's bowel there, and then we inject the contrast and you can push things out of the way. Again, it's important to remember your anatomy. So one of the things that we can injure when we do the freezing, because it runs on the psoas muscle, the genitofemoral nerve. So again, if we get near there, I'll try and put some hydrodissection in to protect against that. CO2 is another great thing to use. So the beauty of a gas, a bit like your double glazing, although I don't presume you have much double glazing out in South Africa, but is you don't need much of it to protect against the ice. So here is a case. Here's the tumor in the left kidney medially. You wouldn't be thinking about the ureter when you were planning this. However, when you turn the patient prone and put your needles in, you can see that that is the ureter there. Here are my needles coming in. What I don't want to do is freeze the ureter. So the next thing I do is I put a needle into the renal sinus. I inject some carbon dioxide, and then you can see here is the ureter in the middle. Here is the carbon dioxide surrounding the ureter, and we protect from the ice with only a few millimeters of CO2, but it works very well. We can do a deliberate pneumothorax. So again, when you're sitting in the MDT and someone says, can you do a cryotherapy on this upper pole lesion? Well, you can already see with them lying supine that there is lung in the way. So that's only going to get worse when you turn them prone. Does that matter? No, it doesn't. So here you can see there's a huge amount of lung in the way. If you stick your needles through the lung, you will cause trouble. So what I do, even with turning them on the side, as I said, let's turn them on the side, see if that works. No, it doesn't. So what we do is we create a deliberate pneumothorax. You just get a little green needle, put it into the pleura, inject some CO2, and the lung will go down. Now, this is not like causing a normal pneumothorax, i.e. I have not punctured the lung. I have just put CO2 into the pleural space. So then that takes the lung out of the way, and then you can put your needles through there with impunity. No problem. And then there we go. And at the end, you just inflate the lung. How do we follow up these patients? So I do triple phase scan. And what you want to see is no enhancement. You can sometimes see some peripheral enhancement at the edge of the lesion. So here's a lesion. Here it is. We've treated it. And this is what it looks like following treatment. So it initially is large, so it's larger than the original tumor, but then it shrinks with time and it can disappear completely and it can calcify. Young patients, their ablation zone tends to completely disappear. Elderly patients, it gets to a certain size and then it tends to stick. As you can see here, it's big, and then this is probably 6 months, it's getting smaller. So that's about it, I think. So it's expected. So what about it? Renal cancer expected to be one of the fastest growing cancers next 20 years. So that's going to increase cost and pressure on neurology departments. I really dislike it when people talk about ablation versus partial nephrectomy. I think it is a collaboration, and hopefully I've shown you that actually certain lesions, certainly the posterior ones, would be ripe for ablation. It is very useful in the solitary kidney. It's very useful in VHL and people with poor renal function. So do think about it. It's going to make your urologist's life easier. It is definitely cheaper than surgery. I don't know if cost is a huge issue out here, but if it is, you should look into it because it is definitely cheaper. Every radiology department's got a CT scanner. Lesion selection is important. As I said, certainly the posterior lesions you should be able to do under local anesthetic or sedation. And if you want to be able to see what you do, then I would recommend using cryotherapy. And this is just a thank you to all my team. Obviously, it's not just me that does this. I have a team of people behind me, some of whom you may recognize. Okay, thank you very much. That's it. I don't know if anyone's got any questions.
Miles, thank you so much. Wonderful contribution to our teaching this morning. You've had everyone wrapped here with, particularly with the clinical cases showing how impressive the technology.
Miles, we're just having a bit of technical issues, yeah?
No problem.
Can you hear me okay now?
I can hear you now, yeah.
Yeah, just to say, nice that you mentioned Chris Anderson. In his telling, he apparently pioneered ablation in the UK. I think they started laparoscopically. I don't know if that's the collective story or whether
Yeah,
Chris is
no. He's part of the cause of everything being so confused. Is that laparoscopic cryotherapy takes, loses all the good bits of doing it percutaneously. But yeah, no, he did. He's absolutely right. He did a lot of very useful work on laparoscopic cryotherapy at George's. He did.
Yes. It's nice to see that we're joined by our interventional colleagues, both of whom I believe have done fellowships internationally. So I wonder if they would like to ask some questions. Dale, I saw you. I'm not sure if Gersh was there.
Hi, Miles. Hi, everybody in the urology team. Thanks for the wonderful chat, Miles. It's great to see the urologists embrace our colleagues in interventional radiology. Yeah, so myself and Dr. Human or Gershwa isn't available at the moment. He's on leave, but our fellow Jatil Kasim is also online. So, Miles, I must admit, very impressive cohort of work. And I mean, we in my fellowship, I had some exposure. I wouldn't say at the volumes that you've had, and really the tips and tricks that you've presented was amazing for us to learn from. And I think definitely I'd like to take your contact details to maybe run some cases by you in future.
Can I ask, what are you using? Are you using micro?
At the moment, we haven't done any ablations, renal ablations, and I think that may be because of our situation from an academic and state sector standpoint. I think most of the time T1A lesions very few and far between in our systems. Usually, when we have renal cell carcinomas, they're quite large when they present. Prof, you can correct me if I'm heading on the wrong direction. But I think that's something that we've seen from our side. I think one of the things I wanted to ask you is that what is your experience with predominantly fatty AMLs that are large, and that we've tried embolizing and aren't really, it isn't successful. Is there a role for cryotherapy in these particular patients?
Yeah,
I
absolutely.
wouldn't say large, I'd say 4 or 5 centimeters.
Yeah,
diameter.
I mean, the first question would be, are you worried about a fatty AML? Because the only risk it poses is bleeding, and actually, if there isn't any vessels in it, then it doesn't matter, does it? But absolutely, you can. Cryotherapy is good for that, and there are a few series out there talking about treatments of AMLs. The problem with embolization, I do embolization of AMLs like you do as well, is that it's quite difficult to 100% get rid of it. Even when you think you've done the best job in the world, they tend to hang around. So absolutely, you could do ablation on that, no problem. And don't worry about the bleeding risk. There isn't really one. It's no more vascular than a normal tumor.
So unfortunately, I have to admit my experience in South Africa with renal ablations is a grand zero.
Oh dear.
But
Okay, well, we need to change that.
We're hoping that these kinds of conversations will help our urology colleagues to send some referrals our way. We're definitely keen to collaborate with you as well to further and to really grow this. As you said, I mean, I think with regards to research, it's very difficult as the interventional radiologist. We don't really follow up our patients. We referred the patients. So how do you compile the data to put together these trials? So it's not our patients. We're just performing a service. So
Yeah.
I think there is definite potential from our side here at the University of Cape Town to try and put this together and really get a South African sort of cohort together and do some research on it. Would be really interesting. But thank you so much. We really appreciate the chat. Yeah.
No, listen, but it's a very important point that you make, and I think, John, you can help out here, because the problem is, I imagine, unlike me in the UK, you are treating, you're not just doing ablations, you're doing every intervention there is under the sun, and I imagine you're very busy with it. But the problem is, unless you are involved with the urologist, I literally sit in an MDT. I spend all Wednesday with urologists. I sit in an MDT with them, and I then sit in the clinic with them, and they come in and say, what about this? What about that? And there's a real kind of relationship. And the problem is, even if I'm away, like I'm out in South Africa now, and I know that when I go back, the number of referrals I would have had for ablation will have dropped, because they'll be like, yeah, let's just do surgery on this one. So you got to try and be present, and you've also got to be helpful, which is why I say
Yeah.
to you, don't be afraid of a great fat patient. Treat them. Try and problem solve for them. Certainly those indications I showed. The poor renal function, VHL patients. Do you have VHL patients in South Africa? I presume you must do. Do you know?
We do, but I haven't seen him come across our, being sent towards us. I must admit though that the interventional radiology system that we've built here is quite new. This is the only really subspecialized interventional radiology practice or department in the country. So it's quite
Okay.
new in the sense of our clinicians are now being made aware of what is actually available with regards to IR,
Yeah.
and we're trying to help grow and teach them. And I mean, this, like what you've done today, is really showing them how cool IR can be, causing a pneumothorax and hydrodissecting, and
Yeah.
that's pretty cool stuff. So I hope they're impressed.
Good stuff. Well, I know a number of people in Boston, so we'll get you set up, and there'll be no excuses. Is that right, John?
No, we are very much in support of Dale and Gershwa's endeavours to grow the service, and we'll do what we can to support them. Can I just ask, Dale, the equipment historically that we always had was RFA for liver mets. Would you continue to use that modality?
No. You mean for renal tumors?
Yes.
Yeah, so we've got access to cryo. We've already been using cryo for recurrent papillary thyroid carcinoma. We've done those particular applications of thyroid, but I mean of cryo. But I think the greatest cohort or most research done is on the kidney, and we'd like to start doing those as well. So be good.
What machine have you got? Do you know?
It's from Boston Scientific.
You've got. Well, come on, guys, you get using it, man.
Tell them.
So in our defence, we have got our first case lined up. It is an AML that was not possible to be embolized, so perhaps not the most ideal first case given its size. But I think as a team, we're going to be motivated to try and find suitable cases to offer this treatment and grow our service. Any other questions, Dr. colleagues? Anything else? Dr. Mandler would have a question, Miles?
Thank you very much. Mine links more with logistics and maybe to help the unit decide to set it up. How did you deal with the problem of getting IR sort of trainees or consultants to take lead in consenting the patients, setting up a ward, monitor them, running or setting up the clinics? For me, as a trainee, that's where usually things tend to be a problem, or to be a clash, or to get sort of where the modalities are not well explained, or patients cancelled on them. How did you deal with that? Yeah, thanks.
I think I know what you mean. I mean, basically, I had to just push for this. So, you literally went and said, we're setting this up, but we want to be taken seriously. So we're going to come to your MDT. We're going to come and sit in your clinic. And then we were lucky enough, because in IR, you tend, unlike surgery, it's a bit of a funny one, IR. You tend not to be given nurses. You tend not to be given clinics. You don't have all the stuff that kind of surgical specialties take for granted. You wouldn't have a consultant surgeon turn up to work and then say, oh, do you want a clinic? Well, you're going to have to apply for that. Do you want a nurse? Well, you have to apply for that. So to start with, it was a bit of a battle, but I've actually got two clinics. I've got one at the Royal Free where I see the patients with the urologists, as I'm in a different room. And the way the MDT works is it says, right, this is a T1A lesion. Can you treat it? Can you treat it? Can it have a partial? Can it have ablation? Yes, both. Okay, T1A options. And those get divided up amongst people. And then they come to the clinic and see. And when I'm sitting in the clinic, I will talk to the patient about the options they have. Getting the nurses was crucial. I think your IR department would benefit massively from having nurses. So the way, what you've got to remember is people, once they let you treat their patient, then it's your patient. And the problem with a lot of IR, you're not set up to deal with that. And therefore, the poor urologist, then you give them back and say, oh, by the way, I've just made a hole in the bowel. Can you deal with it? Whereas what I do, unusually for IR, we have admitting rights where we are. So the patient comes in under me. If I have a issue, then I can ask the urology junior doctors to come and sort of, help out with the patient, but it is my patient. As I said, the most important people were the two radiology nurses I've got. So the way it works is I will see a patient in clinic. I will then say to my team, right, this person needs to come in for an ablation. And they then pre-assess the patients themselves. So within radiology, the patient gets pre-assessed. And the advantage of that is about every problem. You're not relying on a pre-assessment clinic from somewhere else. And it just makes it smooth. The patient knows, I guess what I'm trying to say is that the most amazing thing for our cryoablation service is the patient will see me in clinic. They will then see the nurses, and then they've seen the same people throughout their journey. There isn't anyone else that they see. So they know who we are. They have our contact details and they contact us. So I think if you can manage to do that, but I would say in IR, if you can get some nurses, that's going to massively help you.
And Miles, we are in the works of putting together. We've been given an opportunity to use the day ward, and we are trying to build a clinic. As you say, and I mean very correctly, so that when I ask for staff and clinics and things like that, they're like, why do you need that? Don't you guys just sit in dark rooms and report CTs all the time? And this is the understanding of clinical interventional radiology is still very foreign here. So I think that we are trying to move in that direction so that we are able to actually assist our colleagues and say, listen, we don't want to burden you and say, listen, send us the patient and we'll send it back to you. I think that's the old way of doing things. We want to actually take control of the situation and manage our patients. And then once they've been treated, follow them up. And then if there are any red flags, then you alert our colleagues and say, listen, this is what we've done, and we can discuss it in the MDTs. We are really open to that. We want to have MDTs and discussing these things with our colleagues and really develop this collegiality and understanding that we're not, as you say, not competition. We work as a combined force in treatments of these particular problems.
That is so important, so important. It won't work if you stick with the old school. Occasionally, you'll get referred something because the guys think, oh, this might be good for you. Then it's never going to grow. You need to. The problem is time. It's all time. And I'm very, very lucky that I've been allowed to sort of do this. But this is pretty much what I do. Yeah. But I'm very happy. Yeah, you must get my contact details. I'm very happy to help with anything, including looking at cases or whatever. So yeah.
Thank you for that. We really appreciate it. I don't know, is Prof, are you speaking there? I can't really hear you too well.
No.
I think use Cleve's one, unmute Cleve, and it might be easier to hear because whenever Cleve unmutes, it's easier to hear. So Miles, are you here in Cape Town?
I'm actually in Platt. I was in Cape Town. I was hoping to come and see you guys, but it didn't work out days. But
That should work. Yeah.
Hi, Miles. Can you hear me now?
Yeah, absolutely.
Good. Apologies, we've had some technical difficulties. They always do a generator test on a Wednesday once a month, and despite our pleas that it caused the hospital to collapse. Anyway, my question was, do we need to do two freeze thaws? It's always been convention, but it would appear to put cryo at disadvantage in terms of time.
Yeah, absolutely. And I said that, the honest answer is out here, it depends what you do. I do not do microwave, but there is no question that microwave is very quick and potentially you could do it under ultrasound as well. So, if you used microwave, you could potentially treat a small posterior renal mass in a matter of minutes, literally. So, but I just don't do that because I like seeing and making sure that I have treated what I want to treat. And the only modality that will allow that is cryotherapy. Okay. But the disadvantage is you would have to do that in a CT scanner and it does take longer. But putting the needles in, if you've got a nice posterior lesion, I think you could do a cryotherapy in an hour for sure. But there is no question that it takes longer. But what you're getting is you're getting greater accuracy. And I think, as I just said, for the posterior lesions, you could use anything. It doesn't matter. When it gets more complicated, I wouldn't use anything but cryotherapy. But,
Oh, that's interesting insight. Just to shift the question a little bit onto more advanced renal tumors.
Yeah.
It used to be our tradition to do angioinfarction for a tumor where we expected quite a lot of bleeding. And then we saw some evidence to suggest that it didn't make too much difference in terms of bleeding. So we've moved away from it. Are your urology surgeon colleagues asking you to angioinfarct a big kidney?
No, although I'm always keen to do that. I like embolizing things. And I do think that there is a role. I'm trying to persuade them to let me do the patients who are too unfit for a radical nephrectomy is to just embolize the whole kidney. I've done that a few times with pretty good results. But the angioembolization, there is some stuff of people using it before doing cryotherapy. And the reason that they do it is not necessarily to reduce the blood supply, although I'm sure it does, but is to actually reduce the size of the tumor so that it becomes easier to treat and you use less needles. My only argument about that is you're putting the patient through another procedure because you'd have to do an embolization, which is, it's not that expensive, especially if you use alcohol. I'm a big fan of alcohol in the kidney. But that's another procedure, whereas most of the time we should be able to treat most tumors without doing that. But again, it's something I probably should do, but I haven't done. There's definitely literature on it.
That's absolutely fascinating because there was an era where it was thought that you could perhaps just deal with all renal tumors simply by doing infarction since it's an end vessel. But I don't think that ever really took off. So you've done a few cases and possibly cured the patient.
Yeah, I mean, look, I don't know. I mean, they're all elderly, they can't have an operation, but there is that, I think I haven't done many. I think 6 from memory, and all of them bar one of them was a TCC, and that didn't really help. But the other 5, yeah, it's very interesting actually. It was done for bleeding. Obviously, it stopped the bleeding, but also the kidney just shrunk down. So again, it's something that you could look at. That's some more work for the IR boys.
Yes. Miles and Dale, thanks very much for being part of the meeting this morning. It really has been a great education opportunity for us. Miles, particularly thanks for taking your time on your holiday, and it'd be great to keep up some collaboration with our divisions.
Yeah, absolutely. I think we'd be really keen for that. So I'll stay in contact. That would be great.
Thank you very much. Have a good day.
All right. Thanks a lot. Bye, everyone.
All right.